Hello everyone. This little video on cancer in young and middle adulthood is the end of the lecture. We didn't quite get finished in the common pathological conditions of young and middle adults. So you are at Roman numeral 4 toward the end of that lecture outline. So we're basically going to cover the different types of cancers that you'll see in adults between 20 and 64 years of age. So young to middle adults. Remember, elderly starts at 65. We're going to go through just real briefly some different screening and diagnostic procedures, just so you're familiar with some of those. And then finally, we will talk about 3 forms or kind of stages of care for people in cancer: restorative care, supportive care, and palliative care. So if we start, just as a quick overview, this is not in regards to age, but just for men in general. The 10 most frequent cancers, as you can see, over a 4-year period, was colorectal cancer was really number 1, which might be surprising to you a little bit. You might have expected prostate. That did come in at number 3, but we see colorectal and lung cancer being highest in the percentages. Then prostate, and then liver. Lymphoid neoplasms, so essentially the lymphatic system, and then skin, stomach, nasopharynx, so oral cancers, kidney, and then other types of cancers. So you can see the incidence, and it falls off pretty quickly. So really the top 3, as you can see, colorectal, lung, and prostate cancer. For women, no surprise, I'm sure, to any of you, breast cancer is a huge leading contender, unfortunately. Followed again, number 2 slot is lung and bronchial cancers, and then colorectal cancers. And then we do see again the incidence of the other cancers kind of falling down in incidence as we go. So just to kind of give you a little bit of an overview of cancers in men and women, and which cancers we tend to see the most of in the patients we're treating. I think I have mentioned to you that that the understanding of how physical therapy can benefit patients with cancers just continues to grow and grow. And last year at the House of Delegates for the APTA, the House approved the development of an oncology board-certified specialist in physical therapy. So physical therapists can become board-certified and specialize in treating patients with cancer. So that's just under development. So now what we're going to do is I want to take you through kind of in 4 or 5 year segments and show you how the cancers change in their incidence over time. And this is not anything I'm ever going to ask you about or ask you to memorize, but I think it's really instructive to see which types of cancers are more prevalent in younger adults and which tend to get more prevalent in older adults, and also kind of help you see the types of patients you might be seeing in this age range. So if we start in our 20 to 24-year-old, and again, this is not divided by gender, but it's just by age. So the top cancer we actually see is thyroid cancer, followed by skin cancer. So skin cancer is not just a cancer of old people after years and years, can affect really young people. Lymphoma, leukemias, which are forms of blood cancer, of course, and then brain cancer. So I just did the top 5. In the next age group, from 25 to 29 years, I don't have a slide for this, we still see thyroid as the leading cause of cancer, but now we see breast cancer coming in, whereas in the 20 to 24-year-old range, we didn't even see it in the top 5. Now it's jumped up to number 2. That's displaced skin cancer, making that the number 3. We do see cervical cancer coming in, and again, lymphoma stays in there. From 30 to 34 years of age, we still see thyroid as the top and breast cancer as the 2nd, skin cancer as the 3rd, cervix is the 4th, and lymphoma, so really no change there. When we go from ages 35 to 39, now we see breast cancer again moving up in the ranks, so very strong incidence of that, so we see that as number 1, displacing thyroid cancer. Skin cancer remains there. We now see colon cancer moving up, and again we still see cervical cancer in the top 5. So from 40 to 44 years of age, we have breast cancer thyroid, colon, and then now we're just seeing lung cancer come in as the fifth one. From 45 to 49, breast cancer stays number one. We see lung cancer really bump up there. So now you're looking at people who've maybe smoked for 20, 25 years. We're starting to see the impact of that on their lungs. And so we see lung cancer coming in at number 2 there. We see colon cancer, again, continue to be very strong. Here we now see for the first time prostate cancer. And again, this tends to be cancer that affects men in their older years, but we do see it starting to come in this middle age area. For 50 to 54 years of age, we continue to see breast cancer as the number 1, but now again you see prostate cancer has increased as well. So lung cancer, colon, and skin remain there. 55 to 59 years, prostate and breast cancer, just kind of flipping back and forth. We see the other 3 are the same. And then finally, from 60 to 64 years, we see prostate cancer really far in the lead now of breast cancer. So as women are aging, getting past menopause, we see a decline in the incidence of breast cancer, whereas premenopausally we saw a higher incidence. So that just gives you maybe a little bit of sense of different cancer incidences, not just by men or by women, but across the age range as well. Again, nothing I'm ever going to test you on, but I just think it's important to it helps keep it in context as you're seeing patients with these illnesses. So what do people have to go through in order to get a diagnosis of breast cancer or lung cancer or whatever? Well, certainly a physical exam is very important. So this is kind of the dreaded prostate exam that men have to go through, but it's a very important early sign, though of course we also see blood screenings and things like that, and other imaging being important as well. For women, physical exam for breast cancer, self-exam is really very important, and many women this has been the first time for many women to find a cancer is through their own self-examination and a breast exam. The other thing that's highly recommended, of course, is mammography. So basically with a mammogram, it's like an x-ray of the breast tissue. Not a very fun procedure to go through. They kind of smush the breast down between 2 plates and then they take an x-ray of it. And so on the left you see basically the x-ray, and there shouldn't be solid tissue within a breast. It should all be pretty soft tissue, though of different densities because of the ducts and the glands. Many women can develop cysts or fibrotic nodules, scar tissue in the breast tissue that can highlight and show up as dark. But in this one, they're showing that little dot there indicating a possible abnormality. And then you see, in this case, they show the accompanying MRI, and it's pretty clear that area kind of up in the right center here doesn't look like the rest of the tissue. So this would be positive for a tumor in the breast. It's a little uncertain, or there's been conflicting studies now about whether or not women should do mammography every year or every other year. I think there's enough uncertainty at this stage that certainly premenopausal women should still probably get an annual mammogram. Other way to detect cancer, of course, is with ultrasound, and so many women who have had a suspicious appearance on a mammogram will be referred for an ultrasound, where they can more clearly identify and look at tissue. And again, here, particularly through this area, you can see that this tissue looks different than the surrounding tissue. And as we've talked about before, those ultrasound tech people are really pretty magical with what they can discern and differentiate with just those grayscale images. But that is an important tool that's used. And here we see, I think pretty clearly, an ultrasound of the uterus and the ovaries, and then this ovarian tumor kind of arising out of that. So ultrasound is certainly very good for detecting masses. Though things can, and then one more thing, we'll go to colonoscopy. So again, we're still visualizing things. This is a good internal look where they actually pass a camera up the rectum and then through the entire lower intestine, the colon, and they can show it up on a video screen, and they can clearly identify polyps, irritated mucosal tissue, and of course they could certainly see a mass that was in the colon. So this is a very sensitive and direct way of being able to identify lesions. Many times though, in order to really, oh, I forgot, that's right, dogs can smell colon cancer. So there actually was a scientific article published in the publication Gut, which I'm sure many of you get, which indicated that these, in this case, black labs, were trained and they were able to smell the pheromones and the different chemicals that are released from a person when they have colon cancer. So if I had a choice between getting to play with a black lab or having a colonoscopy, I would definitely pick the black lab every time. But what I was starting to say before is that often, even if something is imaged, in order to determine if it's cancer or not, or if they're pretty sure it's cancer but they still needed to direct treatment, they would take a biopsy of that cancer, of that area, and be able to look at the stage of the cells and things like that to, again, best to recommend treatment. And so in this case what you're seeing is, instead of a colonoscopy, they're doing an endoscopy, so basically coming through the mouth, down the esophagus, and coming to the area here so that they can go through and biopsy the lymph nodes right under the mediastinum, which is kind of right under the breastbone, and in order to determine whether or not lung cancer has spread to the surrounding lymph nodes. We had seen a positive response on a mammogram or an ultrasound, then they can go directly in and take a aspiration or a needle biopsy of the breast, and again determine specifically if there is any cancer or what stage it's in. And then again, just something as simple as skin, I shouldn't say as simple as skin cancer, it's just more surface evident, but being able to take a punch needle biopsy of a potential skin cancer and then be able to assess that. Other more definitive imaging or giving a little different clarity is a CAT scan. So of course with lots of abdominal cavity types things, they would be doing a CT scan. And then there's a whole variety of MRI things that can be done, particularly with color enhanced MRI, that really show, and you can see a big area here in the occipital lobe, but all these turquoise colored areas are signs of metastasis throughout the brain, whereas the normal color on this MRI, in other words, in this case, was kind of this yellow orangey color. So here you see the eyes up here, so here's the occipital lobe. And then a final way that I just wanted to share with you, oh, I'm sorry, this is another color enhanced MRI of breast cancer. In this case you can see it's the yellow orange, that's the tumor, and then the kind of this purplish blue color is the normal tissue. So the last thing I want to share is bone scanning, and many cancers of course metastasize to bone. We do see some primary cancer in bone, but we more typically in older young and middle adults, if we're looking for metastases, we're going to see them as a secondary site. So breast cancer, for example, frequently metastasizes to bone, and so they'll do a bone scan to highlight, and you can see that this is not a bone scan, this is just an x-ray, but they're showing here a tumor growing here, but then also breakdown of the bone and an actual fracture here. This is a bone scan. Basically what they do with that is they inject a dye that will get taken up in an area of high cellular activity, and so of course cancers are delineated by lots of cellular activity, lots of cellular growth, and so here you can see again with breast cancer, that in the pelvic region they've taken up a lot, and you can also see some in the vertebra. Now this one here up in the shoulder, that's more likely to be osteoarthritis than it is a metastatic area. They tend to see metastases in the spine and in the pelvis and the proximal femur areas, and as you can see here, the ribs. And usually they can use other imaging to rule in or rule out, because again, all this is showing is just uptake due to cell activity. So if there's an inflammatory process due to arthritis, that's going to look like a lot of cell activity as well. And then here's one more, again, prostate cancer, another example of where you'd see a lot of metastasis, common metastasis to bone, and so they're showing a couple areas here. So these are just some of the tools that, again, you'll have. These are the types of tests that you'll hear patients talking about going through, and I think it's just helpful if you know a little bit about what those tests are for and what they would show. So from a treatment perspective, of course, we kind of have three main ways to treat cancer. Certainly surgery can be used to remove a tumor. That can be done on its own. It could be done in conjunction with radiation. Radiation could be done on its own. It could be done in following surgery. We could have chemotherapy. So it could be any kind of combination of these things, and many people do undergo a combination. So, you know, my mother, for example, initially underwent radiation and chemotherapy for her throat cancer, and that was successful initially. It definitely shrank the size of the tumor, but unfortunately it did not get rid of it. And so when the tumor recurred, the only way for her to try to have a cure was to have surgery. And so then she underwent surgical removal after that. Other people, of course, would do surgery first, then followed up by chemotherapy. My dad had pancreatic cancer, so he did surgery followed by radiation, but not chemotherapy. So it really depends, and there's quite a variability. But what we end up seeing in physical therapy are kind of the side effects. One of the huge side effects of any cancer treatment is fatigue. And there's a lot of evidence that physical therapy can be very beneficial in diminishing fatigue for patients specifically going through cancer treatments, and also diminishing experience of pain. So the three phases, and again, these aren't specific to physical therapy, but I've included how physical therapy would focus on it, is in a restorative phase or restorative care. And this is where the patient is undergoing treatment for their cancer, but they definitely are expected to recover and resume their normal activities. So if we were seeing someone like that, then we would want to target that aerobic exercise to make sure that, again, we were really focusing on those fatigue issues and trying to improve their activity tolerance. And so that, depending on their starting point, they might be only doing this for 15 minutes a day at a low intensity, but we might be able to also see someone who can tolerate 30 to 40 minutes a day at more moderate intensities. So we would kind of have to assess, and again, for patients like this, I would use more of a rate of perceived exertion, and use that as my key to how to do the intensity. Depending on where their cancer is, and especially if they had surgery, exercises to improve range of motion, maybe enhanced with manual treatment. So if you think of a woman who's had breast cancer, she had a mastectomy followed by reconstruction, there'd be a lot of tightness, obviously in the upper thoracic and shoulder area to work on. Again, my mom had a neck reconstruction, so she needed a lot of work in the shoulder, but also in the neck, head and neck range of motion area, and a lot of soft tissue that was reconstructed that was very stiff and hard for a while. Certainly strengthening as a way to focus not on both strength and activity tolerance, and starting again at some pretty low repetitions and building that up to the 10 reps in a more gradual fashion. And then, of course, the other functional mobility activities that the person needs just to be independent in their life and whatever they need to do. Other areas, of course, the psychological support that may come partly from us, but of course partly from other professionals and other support mechanisms the patient has with their family and friends. And we'd want to share whatever information we could with the family about, how the person could safely increase their activity and what that would require. In supportive care then, this is a person who has cancer, but we can definitely minimize their disability, so they're not cured, but they're not dying. And so really we would use a very similar approach to restorative care, again just really going by what taking cues from the person's physiological status as far as their activity tolerance. And then palliative care is someone who is going to have an eventually fatal outcome to their disease, and their level of function is going to decline along with that. And we're going to talk more about this also with the elderly when we talk about death and dying, but of course when someone has cancer, really regardless of age, they could have ultimate death much earlier than when they become elderly. So regardless of age, we would focus on really talking with them about their quality of life and what their goals are, and helping them to maintain whatever activities they want to be able to do in the most comfortable, again, least energy taking way that we can. So focusing on energy conservation. And a lot of that, again, might relate to as they become very ill. Maybe they're not really getting up or transferring, or maybe they're staying in bed, looking at positioning and ways to protect the skin, if they are, and ways to help, whoever the caregivers are, whether it's family or professionals or a combination of both, being able to safely do some bed mobility, moving and positioning and position changes. If they are transferring, safe and comfortable ways to do that. Again, ways that would diminish the risk of injury for both the patient and the caregiver. And definitely pain management. You can imagine people with terminal cancer may well be users of opioids or other narcotics, and that certainly is appropriate. In addition, though, I think we can, from a physical therapy standpoint, offer other forms of pain management that would help keep the person comfortable and diminish the amount of medications they may have to take. And some people really just, as they become more ill, their body really can't metabolize those medications, and they aren't as effective as they had been. So I think we have a lot of pain relieving mechanisms to offer for patients in the palliative phase of cancer. So at the end, you can see you have two case studies, one on a younger woman with breast cancer, and another one, 61-year-old man who underwent treatment for prostate cancer. So again, we'll figure out, I'd encourage you to collaborate with your classmates and work on these, and we will figure out some ways to share ideas on Blackboard. Thank you very much, and I look forward to talking to you again soon.